the bone-related electrolytes and burn injury as a follow-on from what Shelley started last week with magnesium. And I blame her entirely for choosing these topics, which in the end have proven to be quite complicated to be able to give you a sort of a summary. And unfortunately, there's still a lot that is unknown around the mechanisms for some of the electrolyte issues. But we'll talk about what we do know and some of the things that can be done practically to address them. And calcium phosphate, vitamin D, parathyroid hormone, albumin are all very much linked together and quite difficult to separate out from each other. And the mechanisms are quite complex. And just to set it off, though, a lot of the derangements stem from the hypermetabolic response, which we talk about a lot, but it really is the pinnacle of sort of the response to burn injury. It's proportional to burn size, and we know that the resting energy expenditure can be increased anywhere from 120 to 180% of normal, and that can continue even up to a year after healing of the burn. It also leads to elevated lipid turnover, muscle and bone wasting, as well as insulin resistance. And long term, that muscle wasting leads to limited functional capacity, as well as limitation in participation of daily activities. And this would be over and above specific limitations due to joint involvement, contractures and amputations, increased fatigue, and then, of course, psychological distress. Even muscle regrowth after critical illness, such as in burns, there's a lot of regenerative capacity that is lost and weakness can persist. There's also found to be much higher prevalence of post-burn fractures in children with burns versus children that have not sustained burn injuries. And the prevalence of bone density disorders is much higher in children and adults in their later life after sustaining a severe burn. And obviously, the aim is to prevent muscle mass loss and strength loss, as well as to restore muscle function as early on in the rehabilitative process as possible. And hence, involvement of your multidisciplinary team on the day of admission is important. So to start with phosphates, it's a major role in intracellular metabolism. It's absorbed by the intestine, which is facilitated by 1,25-dihydroxyvitamin D, and it's renally excreted. The majority is stored in the skeleton, but some of it is stored in skeletal muscle. And obviously the high ATP turnover and burn injury with increased muscle synthesis and breakdown leads to increased demand for phosphate, increased excretion, as well as increased losses through exudates, leading to hypophosphatemia. Burn injury also leads to a hypocalcemic, hypoparathyroid state, and the parathyroid levels remain reduced even in relation to calcium levels that should stimulate increasing parathyroid hormone. It's also linked to defective magnesium retention and metabolism. You've also got a high calcitonin, and even though you've got low calcium levels, you've got abnormal urinary excretion or calcium wasting, and within the bone itself, distorted bone homeostasis with increased bone resorption and inhibited bone formation. Vitamin D, not too much is known about vitamin D. We know that there's a deficiency, but not quite sure exactly when it is. There's also a progressive deficiency over time, both in the acute phase as well as in the long-term phase. Vitamin D deficiencies are seen even in patients where burn wounds have healed. And there are correlations between serum levels of the 25-hydroxyvitamin D and the bone density. Further, following burn injury, the skin is biochemically abnormal, and the quantity of vitamin D in the skin of the burn scar that is biopsied, as well as in the normal appearing adjacent skin, is depressed. The precursor of vitamin D is also significantly reduced in skin following burn injury, preventing normal synthesis of vitamin D on exposure to sunlight. And again, the exact requirement for replacements are not really well known or well described. Zinc has a role in the cross-linking of molecules of type 1 collagen, and zinc is leached out of bone following burn injury. Plasma zinc remains low, urinary zinc excretion is elevated. It also plays a role in the inflammatory response, and of course there's high concentration of zinc in burn wound exudates. Replacement for zinc is a bit more sort of known, with 10 milligrams daily given per os in children and 20 milligrams daily per os given in adults. For the phosphate and the calcium replacement, this is part of our standard protocol, and we're using potassium phosphates and calcium gluconates just because there's slightly less calcium sort of concentration, making it a little bit safer to replace. And there are the doses that you see: 1 millimole per kg in children, or 2 amps in adults, 40 millimoles, and the calcium will be 0.5 moles per kg in children and 20 moles in adults. We usually mix it in ringers at 100 moles volume, and children running at 5 moles and adult running at 10 moles an hour. Consider mixing it in less ringers lactate, so 50 moles, if the volume of fluid that the patient requires is limited for a number of reasons. So it can be mixed in different volumes. This is just one way, which is our way. The main thing is that it should be given sort of slowly over a few hours, and it's not a bolus dose or bolus replacement. And then some other more therapeutic options that I thought it would be interesting to let you know about, although availability is limited in our setting. Not to mention that these are the things that should be sort of looked to once you've got the basic tenets of burn care right. And by the basic tenets, I would mean managing infection, early surgery, which, as you know, is of limited access to us. So this slide is predominantly around getting you to understand the theory. It is most certainly not to promote that we should be doing this in our setting. I think there's lots of more basic things we need to be addressing before we're looking towards these things, with the exception of early enteral feeding, which of course we do achieve, and I think we get that right reasonably well, with 2 grams of protein per kg per day in adults, but up to 3 grams of protein per kg per day advocated in children. And of course feeding should be done within the first 12 to 24 hours following a burn injury. Oxandrolone, anabolic steroid in oral form that is safe for both females and children, has shown to be beneficial, particularly if combined with an exercise program. And there's a couple of studies that showed a lean mass increase by 7% if oxandrolone is done together with an exercise program compared to oxandrolone alone, and showing bone content and density improvement sooner in combination. Propanolol, So a beta blocker positively affects the metabolic rate, cardiac function, liver function, as well as beneficial to the musculoskeletal system. Again, there's lots of problems and complications with using propranolol, and should only be done in a well-established burn ICU setting. Because of that, so again, I would definitely not advocate its use in our settings, as none of us looking after burns have access to a burn ICU. Recombinant human growth hormone has been described, but there's not much literature showing good evidence. So it's talked about, but not widely used. Similarly, with bisphosphonate therapy, it is described with acting as an anti-resorptive agent to attenuate bone loss and prevent loss of mineral contact with improved density. But again, there's no clear guidelines to follow. And then insulin is used to modulate hyperglycemia, but it's also been noticed that exogenous insulin can increase protein synthesis and result in a positive net protein balance, and has an anabolic effect on bone. Again, the problem with an insulin infusion in a non-burn ICU is the risk of hypoglycemia, which is catastrophic and definitely causes death. So the risk-benefit ratio is unfortunately not there for us, and I would be hesitant to promote the use of insulin infusions routinely in the ward. But certainly the other thing that we can do is resistance exercise programs. They are efficient in improving muscle mass and strength in the rehabilitative stage of injury without aggravating hypermetabolism. A 12-week in-hospital supervised program incorporating aerobic conditioning 6 months post-burn showed that pediatric survivors improved their lean mass by 6.4% on average compared with the non-supervised home patients. Similarly, there are beneficial effects of supervised programs in adults with healed burns. And burn survivors randomized to a 12-week isokinetic program improved their muscle strength to levels comparable to uninjured individuals, whereas the no exercising group maintained significantly lower values. And these findings underscore the importance of including exercise training as part of, well, both inpatient and I think what we should look to development of an outpatient burn rehabilitation program in order to restore muscle function. And I would use this as an opportunity to challenge our physiotherapists to potentially develop something and start instituting it. Because in the face of a number of therapies available, we really only have early enteral feeding and exercise training available to us. So in summary, there are a number of complex interactions defining calcium phosphate, magnesium, vitamin D, and zinc metabolism. And there are major disturbances to these caused by burn injury, and much is still unknown. A lot of the pharmacological therapies are not accessible to us, for example, vitamin D, or more complex to manage like the propranolol. I think we should focus on getting the basics right, namely early enteral feeding. For a start, just checking the calcium magnesium phosphate, which is often not done in non-specialized burn units. So looking for the deficiencies and managing them. Zinc supplementation, we don't have access to doing levels, but it's reasonably safe, and we just routinely prescribe zinc to all admitted patients and any outpatients with unhealed wounds. And then, as I've mentioned previously, I think this could be a challenge for us to develop a resistance exercise program.